Assalamu alaikum. The short clinical day. First scenario, you will examine Mr. Ali, 35 years old, with a complaint of breathlessness on exertion. Please examine his cardiovascular system. Ready, Dr. Henry?
Yeah.
Yeah, here you go.
Hello, I'm Dr. Henry, one of the doctors here. I've been asked
Yes,
to examine you. May I please confirm your name and age?
I am Ali. I am 35 years.
Okay. I want to gain your consent. Do you mind if I examine you to involve me looking at your body, then putting my stethoscope on your chest and listening to your heart? Is that okay?
Okay,
All right. So I will sanitize my hands and ensure my patient is in 45 degree. Go to the foot of the bed. Position my patient very well. Look at the legs. Check for any vein aversing scar on the legs. Look at the hands. Check for any scars in the hand. Check for any clubbing. Check for any gainway lesions, any splinter hemorrhage. Check for any osseous nodules. Then
no,
okay. Then look for the palm. Check if the palm is sweaty. Then check
no,
and then okay. Then look at the pulse. Palpate the pulse and see and calculate the pulse. 10 seconds. What's the pulse like?
pulse, pulse.
Yeah, pulse.
Okay, pulse is uh 85 beat per minute,
Okay.
large volume,
Normal volume.
large volume.
Large volume. Okay. So I do my collapsing pulse.
Yes,
Collapsing pulse.
positive.
Positive. Okay.
It's
Then
collapsing.
it's collapsing. Okay. Then I check a radar delay and radiofemoral delay.
It's okay, normal.
Okay. Then check for
Radial or normal.
okay. Check thickening arterial wall. Check the any locomotor brachialis. Check for the blood pressure.
Blood pressure is 140 over 60.
140/60. Okay. Then check for. Can you please check for the JVP and ask him to look for the other end and check is it elevated the JVP
GVB is not elevated, but there is pulsation in the
position?
neck.
Okay.
Yes,
Okay. Carotid position. Okay. Then look at the
yes.
eyes and look at the check for any pallor.
No,
Okay, then look at the mouth, check for any eye arc palate, check for the any cyanosis.
no,
Okay, then look at the check for any precordium, check for the any scars in the chest, any scar,
no, no scar.
no scar. Then check for the and look for the check for gynecomastia in the breast. Observe for the any apex, the apex displace, any device there.
No device. Apex
Okay,
is outside
palpate for the apex.
clavicular line.
Okay, okay. Pardon, what's the apex?
What?
The apex is it displaced?
Yes, this place.
Okay, then check if it's heaving or if it's diffuse or if it's tapping. Okay, then
It is thrusting.
trusting. Okay, then ask, okay, then I put my stethoscope and then so before I check for the heave, any apical heave and left personal heave.
No,
Then check for the trees in the aortic and the pulmonary area. Check any trees and then the mitral area, any trees, no trees. Okay,
you
then I
mean
put
murmur? There is murmur.
any trees, any
Um,
palpable trees, no trees. Okay.
huh?
Any palpable trees? Can I palpate any trees on the aortic area, the pulmonary area, and check hospital? No trees. Then check for the murmurs. Any murmurs with accentuation?
Yes, yes, there is murmur in the
Okay.
second aortic area,
Any
which
what?
is the
Aortic area.
systolic murmur.
Okay, that's really murmur.
Yes,
Okay. Then ask him to lean forward and breathe in and hold on expiration. See, is it increased?
yes,
Okay, then palpate and check for the carotid murmur too. Any buoy for the carotid, any carotid buoy.
no,
Okay, then go to the behind, check for the any bilateral crepitation.
no,
Okay, then check for pitching, any sacral edema. Before checking that out, ask him, do you feel any pain? Then check for both sacral edema and pedal edema, any pain, any edema, sorry.
No pain and no edema.
So I want to then check for the check permission to check for the femoral, check for any check for the trop sign and the pistol shot sign in femoral area, and then end by checking for the uvula, asking to open his mouth and check for the uvula. If the uvula is
1
positive,
minute left.
is the uvula positing?
No, not clear, not clear.
Okay, then
Only
also
clearly bouncing pulsation over carotid area
work
or
out
over
there.
neck.
Okay.
Neck, yes.
Okay. So thank my patient and sanitize my hand.
Okay, thank you.
Okay, examiner questions.
Okay.
4
Okay,
minutes.
can you present your case?
I've examined this young man who on internal examination, I noticed he has the peripheral pulse is 85 beats per minute. There's a collapsing pulse. There's also pulsating carotid, and also with wide pulse pressure as evidenced by 140/60. Apical examination, precordial examination shows diastolic murmur, early diastolic murmur in the aortic region, which increased by leaning forward and on expiration. However, there's no evidence of stigmata of infective endocarditis, no pulmonary overload, or every patient is not in failure. I want to end my
Okay.
I want to complete my examination by doing checking the blood pressure on the lower lip and upper lip to compare, and at the same time do bedside ECG and ambulatory blood pressure monitoring. Bedside ECG. Thank you.
Okay, thank you. What is your differential diagnosis?
My differential diagnosis in this case is severe aortic regurgitation with differential diagnosis of severe pulmonary regurgitation, and also also thinking of aortic regurgitation, pulmonary regurgitation, and then aortic atrial septal defect. However, yeah.
Okay, okay. What are the cause of aortic regurgitation?
And the cause of aortic regurgitation, it could be acute or chronic. Acute cause may be due to myocardial, may be due to infective endocarditis, may be due to trauma, may be due to repair from aortic stenosis repair, also may be due to um, infarction, and also may be due to then chronic cause may be due to congenital disease such as connective tissue disease such as Marfan syndrome, may be due to infections such as syphilis, may be also due to systemic disease such as systemic lupus erythematosus, also may be due to ankylosing spondylitis, and also adult polycystic kidney disease. Thank you.
Okay. How will investigate this case?
Investigation of this patient, I want to start by doing bedside cardiovascular observation, such as regular post pressure monitoring, BP check, and also bedside ECG, chest X-ray, in which I expect to see in ECG there may be evidence of left ventricular hypertrophy. Also, there may be by chest X-ray, there may be evidence of large cardiomegaly, and also echocardiography, in which we further confirm my diagnosis, in which there may be evidence of regurgitant jets on echocardiography, and also heart left heart catheterization to rule out evidence of pulmonary hypertension. Then also BNP and pro-BNP to check the evidence of heart failure, and also baseline routine tests such as routine food blocker and differentials. Also underground genetic study to rule out genetic disease, and then auto antibodies to rule out underlying systemic conditions such as SLE and rheumatoid arthritis. Thank you.
Okay. Um, How will treat this patient?
Management.
Yes, management.
Okay. Management of these patients will include a multidisciplinary approach, which may be based on as either um, non-pharmacological, pharmacological, and surgical. A part of my management, medical management will involve the use of medication, such as um, if patient is in since patient is having breathlessness, and patient is meant to give some medication to such as beta blockers and also yes, and ACE inhibitor if need be. Then part of a surgical intervention if there is evidence of if patient is if there is evidence of indication for surgery as evidenced by um, uh, left ventricular dysfunction, or patient may be tempted to be, or there's severe aortic regurgitation that is symptomatic. Patient may benefit from surgical information, surgical interventions such as um, uh, aortic valvular replacement, which may be either through TAVI or through surgical aortic valvular replacement. They're not surgical, but
When will go to surgery?
surgery in surgery is usually for usually seen in young patients that are with little that or if they have other comorbid heart abnormality, also is an indication for surgery. If they also have if that's miss other heart condition outside the aortic regurgitation, the indication for surgery. If the patient is young too and can withstand surgery, is also an indication for surgery. And also um, yes, these are the indication for surgery in this case. Is this an indication for surgical other than TAVI? Then for TAVI patients, usually for patients that cannot withstand surgery, such as elderly patients, and also patients with I think basically, yeah. Thank you.
Okay, thank you. Thank you. Dr. Basim.
Yes, Dr. Salma, you can comment now based on the skills. So, starting
Uh,
from the physical examination, the steps.
okay. I think it's done very well. Um, uh, when I ask about causes, it's okay, is mention it, but if
No,
mention like valve,
Dr. Salma. Let's go
uh,
step by step and skill by skill. The physical
okay,
examination, he did the steps well, so it's satisfactory,
yes,
right? They
yes,
identify the finding. He picked up most of the finding, like
yes,
the regurg, the apex,
yes,
the pulse,
yes,
the volume, the carotid
yes,
pulsation, right?
yes.
And he offered also blood pressure.
I don't
And
know,
he,
is asked me to see, want to see the mouse or no?
no, I don't think. But he asked about splinter hemorrhage and Genoa lesion or
Yes,
nodes.
yes, infective endocarditis always asked. But
Yes, okay,
because I'm waiting to ask me about mouse, because I want to tell him this patient has
perfect.
a high arch palate.
I
So,
mentioned it. I mentioned it. I asked. You said no. I said
Re-
any I asked palate. I did.
really? I'm sorry,
Yes,
I
I did.
didn't.
so you
أنا
ask
مرات
about
بلقى صعوبة صراحة في إنه شوية كده
Mm.
yes, okay.
أيوة.
I think Dr. Henry, today you sound like sleepy or I don't know. Yeah,
I'm not with my headphone. I'm in the room. So
Little
yeah,
far,
you are
little
not
far.
in the mood. Yeah, you're
no,
not.
I'm the mood. I'm in the room. I'm not in with my headphone. That's why.
Okay, yeah, okay. For
Okay,
your case, try to be more loudly talking. Okay,
Okay.
okay. So we'll give you the
okay.
satisfactory also for finding. I defined the finding. The next
Yes,
question for clinical judgment. Did he
yes,
mention during presentation the signs of infective endocarditis? It's very important.
yes, 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 mention.
He did so. Okay, and the
Yes.
investigation he included
Investigation, yes, I think, yes. Mention also, yes, ECG, echo, no, 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 I think it didn't mention.
blood culture.
Routine, no, no, I didn't listen routine. I listen only ECG, echo, and cardiac catheterization.
Okay,
I don't know, mention
if we
series ولا.
repeat it again, Dr. Henry, starting from general CBC investigation as CBC and coagulation. Did you mention the coagulation?
No, I did not mention coagulation.
Okay,
I did not.
CBC and coagulation profile,
Mm.
kidney function, liver function, as general. What about the specific?
A specific ECG, chest X-ray,
No,
echocardiogram.
ECG and echo bedside test, specific
That's
for the case here.
I mentioned chest X-ray. I mentioned coronary angio, and then for prior to intervention, and then catheterization, heart catheterization.
Okay,
With
this is an
pulse.
advanced answer. Sorry. What before that? What you can do before the catheterization and PCI, coronary angio? What do you think can help us if this patient in heart failure or in MI, any labs specific for that?
Yeah, I mentioned BNP and then cardiac markers.
Perfect. Yeah, so these are the specific investigation for any cardiac case. Okay, in particular, the naive valve. If there is metallic valve, you have to mention the coagulation profile. It's a must. They are asking about it. If you didn't mention, they will minus you and they will ask you what do you think about the coagulation profile. So whenever you have replaced valve, you have to speak about the coagulation profile and the target INR. Okay, they recommend this part of discussion. So again, the specific investigation for any cardiac station, put in your mind, you have to mention the PMB and troponin. Okay, now the bedside tests. You mentioned the chest X-ray, ECG, echo, right? If there is arrhythmia, you can mention also the Holter, right?
Yes.
Okay. Blood culture, as I said, it's one of the blood of specific investigation you can mention whenever you are suspecting infective endocarditis. Okay, so the clinical judgments as investigation, you cover most of them. You mentioned even the PCI and the echo ECG, which is very important, chest X-ray to rule out heart failure. And again, don't forget the blood culture for infective enteritis. What the role of echo in this scenario?
Echo is want to diagnose, to confirm the diagnosis, and also to assess the severity of the aortic regurgitation.
So
And
yeah, put it as a scheme for any echo patient or any cardiac patient. You want to do echo for him. You have a lot of finding or function in the echo to confirm and to do other investigation. For example, to assess the cardiac function, ejection fraction, right?
yes,
Either systolic or diastolic. This is one
yeah,
of the important. So I will assess the cardiac function, either systolic or diastolic. And to confirm my diagnosis, the valvular lesion, if there is valvular lesion or there is a valve replacement. So I have to talk about this. And to rule out other valvular disease. Sometimes there is other valvular can be occasionally found during the echo, right?
yeah.
And to rule out infective endocarditis. Okay, although it's not very obvious with the transthoracic one. If you want to check for vegetation, you have to do what?
Vegetation have to do with transesophageal.
Perfect. So you can mention it. Okay.
Thank you, Dr. Basil.
Okay. In treatment, when mentioned treatment, I think you mentioned beta blocker. Beta blocker in this case should be avoided, but we can give ACE inhibitor.
Yeah. Thank you. Yeah,
Yes,
yeah. You're right. You're right. Yeah,
yes.
that's true. Yeah, I'm mistaken. Yeah, correct. I agree. I agree with you. Yeah, I agree. I agree. It was slip of
Thank
tongue.
you. Thank you.
Yeah,
Yes, thank you very much.
I agree. Okay, Dr. Basil. Hello? Hello?
Yes, I can hear you, but maybe Dr.
Okay.
Basim is little
Okay.
far.
Okay, I thought I have lost contact.
No, it's not lost.
Okay. Actually, I want to ask of the
You have
check for
scenario?
EVD.
You have a scenario,
Yes,
doctor?
I've sent it to Dr. Basim. I've sent it to Dr. Basim.
Ah, okay. You didn't send it in the chat box?
Okay, let me send it in the chat box too.
Okay.
I've sent the picture to Dr. Basim. So a 40 years, 40 years.
Sorry, Dr. Yanari and Dr. Salma. I can
Just
continue the comment, Dr. Salma. Differential diagnosis.
Differential diagnosis is good. Yes.
How was the differential, Dr. Salma? Sorry, I couldn't hear you.
Is mentioned good for differential diagnosis.
So can you repeat again the differential
You
of...
can give.
Okay, I mentioned aortic regurgitation. I also mentioned pulmonary regurgitation. And then I mentioned atrial septal defect.
Why you mentioned the ASD? What the relation or what the similarity between
Mention
both?
ASD? No, ASD because ASD is the band. Is VSD or ASD? ASD ejection systolic murmurs, huh? Not
So
diastolic murmur.
you are talking about diastolic murmur. What are the other diastolic
Yes.
murmur you can hear?
Okay, it could be also a mitral stenosis. However, mitral stenosis usually in the
Perfect. So
area.
it will be mid diastolic murmur. So you have to mention the mitral stenosis. So you have the pulmonary regurg or aortic regurg as early diastolic murmur, and the other differential will be for mid diastolic murmur, which is mitral stenosis. Okay. The other management always mentioned the involvement of multidisciplinary team approach. And there was a question, is it jargon? Yes, whenever you are talking to the patient, don't say multidisciplinary team. So you can say group of doctors. For the for the examiner, yes, multidisciplinary team approach, safely you can say it, and you have to say it. Here, the heart failure, so cardiology, echo technician, specialized nurse, pulmonologist, infectious disease if you suspect infective endocarditis. So you have to mention the multidisciplinary team approach according to the case. And the last definite management will be, what would be the last management for aortic regurg? What the third version will be?
Intervention.
Surgery.
Yes, replacement.
Yes.
Okay.
Or yes.
Yeah. So
If the
aortic,
patient is asymptomatic without sign of severe aortic regurgitation, we can give AC inhibitor. Improve prognosis in asymptomatic patient.
this is the medical or pharmacological option.
Yes.
But
And
for
yes.
for
For
the
surgery.
surgery, if there is symptomatic patient or
Yes. Patient
echo finding.
symptomatic. Yes.
Yeah, echo finding. What are the echo finding you can say?
Left ventricular ejection fraction less than 50.
Perfect. Okay,
And also left ventricular end diastolic diameter.
perfect.
Also greater than 7 and left ventricular end systolic diameter greater than 5.
Yeah. So remember these values whenever you have regurg, either aortic or mitral. You have to speak.
It's greater than 50 and 70.
Whatever you
Yes,
have to say.
either millimeter. If you
Impaired.
mention centimeter, 7. If you mention millimeter,
Okay,
70.
forget about numbers, both of you. Just say impaired systolic function, ejection fraction, or dilated increase in the diastolic diameter. Okay.
Okay.
Better if you mention number, it will be
Yes,
some
maybe
examiner.
confusing us. Yes.
Yes. Okay.
Yes.
So the the welfare was maintained, right? So he got
Yes.
good mark. I will write the mark now. Now your turn, Dr. Selma. Patient name. He's 40 years old. Mr. John Smith came with cardiology follow-up. Start examination.
Okay. Hello.
Hi, doctor.
I'm Dr. Ahmed. I'm doctor in the clinic today. Can I confirm your name and age, please?
I'm Mr. John Smith. I'm 40 years old.
Okay. I will examine you. If you feel any pain or discomfort, let me know. Is it okay with you?
Yes, doctor.
Okay. So I will start my examination. I will see for any surrounding oxygen cylinder or any surrounding to the patient. Then I will start my examination by hand examination or clubbing for any in the nail. I will check for clubbing and for splinter hemorrhage in the palm. I will check for any palmar erythema or I will check for any osseous node or genuine lesion.
Absent.
Okay, I will check pulse.
Okay, the pulse is regular. It's normal. It's 80 beats per minute, regular, normal volume.
Okay, synchronous, not collapsing, no radiofemoral tray.
No.
Okay, I will also check blood pressure.
Okay, blood pressure is 120/80.
120 or 80. Okay, then I will examine eye for any color jaundice.
There is no pallor, no jaundice.
I will examine mouse for any mouse
Have you seen
hiding and
have you seen
deviating
the
easily
picture?
from that.
Yeah,
Do you
you've seen
think?
the picture. I've sent the picture.
Okay, not showing yet. Okay,
Okay.
I will check for JVB. Is it raised or no?
No, it's normal.
Okay, okay. I will inspect the chest for any scar.
And you can see the chest. I've sent the picture.
Okay,
The
send the
tabaxi.
picture. Then I will go at the end of the bed. I will check for also any lower limb edema, any scar in the shin or in the foot. I will check also for peripheral pulse,
Yeah,
dorsalis pedis pulse.
there's a scar on the chest, but there's no scar on the
Scar.
on the on the
Okay.
chest. Mm.
Okay, there is a scar in the chest. Is it midline sternotomy scar?
No,
Because
it's
picture is not.
okay. Let me show.
Not.
Okay, don't worry. Let me send
Okay,
the
okay,
picture.
sure. Okay.
So 1 minute.
I think only Dr. Basim can share because host
Okay,
only can share the picture.
okay. All
So
right. Is the Basim there?
No, Emeka, can you try to send the picture to me on WhatsApp? I will try to share it. You can.
Okay,
I'm opening through computer, so I'm trying to help.
okay, okay. Okay.
I'll send you a message for just 1 second.
Okay, okay.
okay, I can continue my examination until
Yeah.
sending the picture because this is time.
Don't worry. Don't
I can
worry.
continue.
Sorry,
You
I will
continue.
share it now. Sorry, sorry.
Okay.
Okay, okay,
There is the picture. I will add 1 minute for you, Dr. Selma.
okay, thank you.
Here it is. Yes, you can see it now. You can see it now?
No, Dr. Basim is still loading. It's
I
open
can
for
see
anyone.
it. Yeah, I can see it.
Yes, now I can see. Yes, now I can see. Okay, okay, okay. Now I can see there is a scar in the okay, uh, okay, left upper part of the chest below the clavicle. Okay, 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 okay. Then I will continue my examination. Uh, okay, uh, okay. I will continue my examination. I will check apex.
Okay.
Uh, okay, apex in place.
Yeah.
Okay,
Apex is normal.
okay. What about character?
Character is normal.
Normal character.
Mm.
Okay, Okay. Also, I will auscultate for heart sound, first and second heart sound.
First and second sound, no, yeah, present.
Okay, normal.
Yeah.
Okay. I will check also for any murmur,
No murmurs.
any palpable B2,
No.
any parasternal heave.
No.
Okay. Okay. Uh, I will I will I will tell to the patient uh, 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 no any murmur in any area.
No.
Okay, I will ask the patient to sit down. I will auscultate again for the second carotid area. If there is any murmur, I will tell the patient lean forward, take deep breath in and out, and keep it. Then I will auscultate again. No murmur.
No murmur.
Okay. Then I will auscultate for also carotid brood.
Okay.
Then
No breathe. No breathe.
okay. Then also I will examine back. I will listen for any basal crepitation.
No basal crepitation.
Also, I will check for any sacral edema.
No sacral edema.
Okay, no sacral edema. Mm, okay, okay. Uh, okay. I will thank the patient. I will cover the patient.
Okay.
Okay.
Okay, I added 1 minute for you. Now you can start the exam.
Okay.
Uh,
Are you done?
yes, yes. Okay, it's okay, doctor.
Can
Okay,
you present your positive findings in the patient?
okay. On examination of this patient, mm, uh, uh, there is uh, uh, there is on examination of this patient positive finding. There is long face, uh, uh, look like myotonic face, long haggard face, and also there is a scar in the left upper uh, upper part of the chest below the clavicle. Most likely this is a pacemaker. Uh, then uh, so apart from normal first and second heart sound, normal pulse rate, and also no murmur, no sign of infective endocarditis, no sign of heart failure or pulmonary edema or pulmonary congestion. So,
Okay.
from the character of the face and the pacemaker device, I suspect this patient has myotonic dystrophy complicated by heart block.
Okay. So, what are differential cause of the scar? If it's not a pacemaker.
Defibrillator.
What else?
If not, if not pacemaker, it will be the cardiac defibrillator.
What else? Other differential of the scar.
Uh, I think this. I know only this two.
Okay. So I will investigate your patient.
Apart from routine investigation and CBC, full blood count, full blood count, renal function, liver function, and also I want to do genetic testing, and also I will do ECG and echocardiography, and I will monitor. I will monitor the pulse also for any bradycardia or any heart block. Um,
Okay. You're done?
Yes.
Okay. Assuming this patient before now presented with left ventricular ejection fraction of 35% with left bundle branch block, then he has a type 3 New York Heart Association of heart failure. What do you think would have been in that scar?
Okay. Maybe ventricular device.
Assuming this patient has before now, he has a left ventricular ejection fraction of 35%, left bundle
Yes,
branch
yes, yes.
block, and New York Heart Association of type 3. What would you be thinking that is in that scar that you see there?
Cardiac resuscitation therapy.
Pardon? You say what? Can you hear me?
As I mentioned, cardiac resynchronization therapy.
Okay, good. Okay, so how will you manage the patient?
I will, if the patient is on, firstly, educate the patient about the condition and admit the patient. And if the patient is on failure, we will start by giving treatment of the heart failure, like diuretic, spironolactone, and if heart if there is heart block, we need to put a pacemaker.
Okay.
Apart from treatment of the from treatment of myotonic dystrophy, there is a cause.
Okay.
Yeah, after AC inhibitor, diuretic, beta blocker also.
Okay.
Okay.
All right.
Okay. You're done?
Okay.
What other scars, Dr. Salma, as Dr. Henry said?
I know
The
that
scar.
pacemaker or either pacemaker or either
Okay.
cardiac defibrillator or
Yeah,
uh,
so you said it, ICD, right?
yes, I mentioned cardiac
You mentioned?
defibrillator
Okay.
and pacemaker.
Okay.
I mentioned
Okay.
two. Is asking
Perfect.
for
Okay.
third one.
Okay, let's hear his comment, then I will be commenting
Okay.
back.
Okay.
Dr. Henry, you can comment now.
And thank you very much. It was a good.
Again, in the skills manner, okay? Skills,
Okay.
physical
In the scale
examination.
manner. Okay.
Yes.
Okay. In the scale manner, let me look at your scale again. Okay.
First, physical examination.
Yeah, physical examination. I will give him borderline.
Okay.
Yeah, the
Why?
reason.
What she meant? What she
Yeah.
missed?
Yeah, she didn't further look at. She didn't show the sign of that she's checking for myotonic dystrophy in this patient.
Yeah. Perfect.
That because
Yes.
of that fact, I'll give her borderline.
Okay.
Then for
Okay. I need to mention in details face like this.
you need to be seen checking for them for the signs of MD in this patient by handshake.
Really?
Yeah,
Oh
Percussion
my God!
myotonia.
Really? Because
yeah.
no time for this. You mean I search for
At
distal weakness
least do minimum of two.
for
They are two tests, Dr. Salma. Two tests only you can do.
okay.
You know them? How to do it?
Yes, hand grip,
Yes, and
slow
release. Okay, and
slow release, yeah. And
myotonic grip.
what? Myotonic grip. Okay.
Sorry, percussion myotonia and hand grip. Yes,
Yes. I
percussion
will percuss
myotonia.
over
Okay,
thinner
yeah,
muscle, then will be
over the thinner.
slowly.
Exactly. Yes.
Yes.
Okay.
Okay.
Yes. Comment on the identify
Then
the findings. This.
yeah, physical findings. At least you identify the findings. But you said something. You said pacemaker. You should have said device. Because you're not sure what is that. So saying pacemaker is it may not
Yeah.
be, it might be other cardiac devices. You just say pacemaker, and also although you comment on some of the findings which was good, your comments on the long haggard face. He comments, but the ptosis that he had, or probably not the frontal baldness. He didn't, but those are things that are fine. But anyway, I'll be generous. I'll give you satisfactory. Yeah, I'll give you satisfactory in the clinical science.
Huh?
Yes, you're able to. Can you hear me?
Mhm.
Hello.
Yes,
I'll give.
yes,
Good.
Dr. Henry, we can listen you. You can hearing you.
Yes, I will give you satisfactory for the clinical science because we are able to pick some of the science despite the fact that you didn't really touch the but at least you were able to you mentioned some of the signs that the patient had MD, which was a good one. So at least you pick some of the signs. So I'll give you satisfactory for physical science.
Okay. If in this case we need to mention in details, I mean, you
No,
need to mention
oh,
frontal balding and also check for cataract and
yeah, these
also
are things. Yeah,
ptosis also and
yes,
also yes.
Yes, you will say
mm,
I can see the features of myotonic dystrophica in the
yeah,
form of 1, 2, 3, 4, 5, whatever the number of the
Okay.
finding. So please mention
Okay.
them because it's related to
Okay.
the case directly.
Yes, yes, it's clear. Long hagar face,
yeah,
clear.
Yes,
Yes, yes.
perfect.
Okay.
Okay. What else, Dr. Henry? The clinical
um,
judgment.
yeah. Clinical judgment. Well, he got the myotonic dystrophy. He got the device, but he just a pacemaker. Although truly, what the patient has is pacemaker. I just put the CRT just to ensure that he got the, but he kind of cooked up sign that was not there. According to the exam, if you say something that you're not sure of, is
Mm.
not a good
I
thing.
need to mention device, huh?
Yeah. Mention that
Uh,
device instead of
Always we
saying
saying only
pacemaker.
pacemaker. We know
Yeah,
that is device, but I need to
yeah,
mention, huh?
yeah.
I
Say
need to
that
mention that
device.
device.
Yeah.
Okay, cardiac device.
Therefore, the management, I was not so your management plan for clinical
Yes,
judgment was not so convincing. I don't know, Dr. Bazin, to me, I'll give him borderline.
yes, yes, yes,
It was
yes.
the
I
clinical
feel
management
that is
plan
not.
was also convincing to me. He didn't manage his patients per se. When I say how will you manage his patients, you
But
keep
she
on talking
mentioned the
about.
multidisciplinary team approach, right?
Yes, she mentioned the MDT, but she didn't
Okay.
tell us the component of the MDT.
Okay. Okay.
And then she didn't mention the plan. Or that, like she said, what this patient need is monitoring, regular monitoring. You need to be visited by the what they call it, the the what they call
ACG, you want to say? Holter?
no, not all. But I'm talking about the management now, not the investigation. In terms of the daily regular follow up,
Yeah, the
management
complication.
of these patients.
The
Yeah,
complication.
complication. Yes, and then
Yeah.
it be seen by
Therapy,
the
occupational therapist.
occupational therapist, and then the pacemaker interrogators, regular visiting of them and things like that. So that each person is on a device. For instance, it could be ICD. It could be like the regular follow up. Vaccine, all those things for heart failure manage for then checking up for regular monitoring of the device. For battery strength, for interrogator, and the rest of things you want to see. Then also for the MD to mention neurologists as part of the management for the myotonic dystrophy. The use of
Yes.
physiotherapy for the dystrophy and other management plans. So because of that, I'll give her borderline for the clinical judgment.
Okay.
Mm.
Okay. Along with the also the follow up for genetic counseling,
Mm.
if there is plan for pregnancy or having a baby, it's important, right?
Yeah.
Why? What the mode of inheritance, Dr. Salma?
Myotonic dystrophy. Autosomal dominant.
Yes,
Yes.
perfect. Yes.
Yes.
Yes, autosomal dominant.
Okay.
So 50% of children will be
So
affected.
you can say genetic
We
counseling
need to
also.
do genetic test, genetic counseling. Yeah.
Genetic
Refer to
counseling.
genetic. Refer to the genetic
Exactly.
better. Said like this.
And the multidisciplinary, in the MDT, you can mention this genetic team or genetic counseling team. Okay.
Mm, mm.
Anything else? And the differential, how does she do?
Yeah, differential, she did well. She mentioned two differential, which was good. Although there are 4 differentials I have in mind in my marking scheme here, but she mentioned 2 out of the 4, which was okay. She mentioned pacemaker. She mentioned defibrillator. Like I said, it could be loop recorder, basically.
You know,
Yeah.
my problem, I didn't mention full name, device, pacemaker,
It could be loop.
implantable cardioverter, defibrillator.
Yeah.
You
It could
know,
be
Dr.
yes.
Basim,
It could be an
I
ICD,
didn't
like you said. It
mention
could
full.
be
And
a
this is not
CRT.
good, I know.
Yeah.
I know, should mention full, yes, should
Yeah.
mention full
So,
name. Yes,
so
yes,
one,
okay.
it could be pacemaker, it could be CRT, it could be ICD, it could be a loop recorder. These are the 4 things that might be, that might be a differential of that scar with the device in there. So typically, she mentioned 2 out of the 4, which in the exam 2 differential diagnosis. Well, I don't know. I'll give you maybe borderline for differential diagnosis. She mentioned 2, which was including diagnosis. Really,
Okay, what third one, Dr. Henry? What's third one? Firstly, device
I
pacemaker,
mentioned
then
it could
implantable
be an
cardioverter,
yeah,
defibrillator. Third one,
yes.
what is the
It could
third?
be a CRT-D or CRT-P. Like it could be a cardiac reconnection therapy, which
Cardiac
was
resynchronization therapy. Okay,
therapy.
okay,
CRT.
okay. Three differential of this scar.
Yeah, I mentioned 4: pacemaker, ICD, CRT, and loop recorder.
Okay.
I think pacemaker also can be in the same place, but it's not directly related to the case.
Yeah. So these are my 4. Okay. Yeah, I think that's it, Dr. Basim.
Yeah, the welfare was maintained, right?
Welfare, yeah, okay, satisfactory.
Okay.
Welfare satisfactory.
Yes. Okay, thank you. Okay, so I will not add more than Dr. Henry mentioned, apart from the occupational therapist. On those people, they need support. There is no specific medication can help, only supportive management, and you can add the genetic counseling to your team, okay?
Yeah.
Can you tell me management again for this case? What is the management?
Yeah,
Yani by systematic way.
Yeah, management will involve a multidisciplinary approach.
Okay.
Cardiologist, the cardiologist, the specialized nurse, the neurologist, the physiotherapist, the genetic counselors, and it will involve both general management and specific management. General management will involve like physiotherapist for the mosaic dystrophy. Then also maybe which patient may benefit from the use of other accessory device. Also occupational therapy should be involved. Then for the specific management, in this case, since patient is having a cardiac device, likely, like you said, if you are thinking of a CRT, like the examiner suggests a CRT for you. So the management that should be management of a left ventricular, management of the CRT. In this case, patient is already on device, so it should be regular clinic follow-up, regular monitoring, and then regular monitoring, then ensure that patient is on his medication, on his medication like you mentioned. Then also part of the MD, the myotonic dystrophy, is to further how will I put it, if possible, screen counsel for screen of other relatives, and if patient is ready if patient is sexually active and wants to have children, to further counseling for future generation testing. That's just the guideline, basically.
Okay.
Okay, thank you, Dr. Henry. Any role of pharmacological option in this scenario? Any medication can help?
Only if there is heart failure, you can give diuretic, ACE inhibitor.
No, apart from the symptomatic
Specific.
treatment. Yeah, specific
Mm,
treatment.
mm,
Do
I
you
don't
know,
know. I
Dr.
don't know.
Himani?
Specific treatment?
Yes?
Mm.
For the MD,
No, there is a medication. Are you aware about it?
yeah, okay. If patient is in, is it medication for the heart problem?
No, it's medication for leukemia itself.
For maltonia itself,
Yeah, mixilitine.
mexalatin. Okay,
Yeah,
Mixilitine?
yeah,
Okay.
mixilitine. Okay,
okay.
for the
Thank you, Dr. Bobby.
stiffness. Yeah, for the stiffness.
Okay, okay.
Okay.
Yeah, anyone want to add any comment for this scenario or the previous one?
So, but in the exam, if you see a case like this, you should go for more of pacemaker. Because typically one of the commonest manifestation of heart manifestation of MD is usually block, a conduction problem first before cardiomyopathy. So if you have to rank this disease condition in terms of hierarchy, pacemaker will be the likely things in this case in the main exam, because of the conduction block is more common than cardiomyopathy and atrial, which is other cardiac manifestations such as atrial fibrillation, cardiomyopathy, and mitral valve prolapse.
Cataract, diabetes,
And
all of
cataract,
them
yeah.
are
All of them, yeah,
complication. You have to mention to treat the complication
yeah.
or to manage the complication if it's there. You can do it in the investigation, by the way. So investigation of the complication
Mm,
for the cataract or for the diabetes, you can do the screening for diabetes, hemoglobin
yeah.
A1C or fasting and random blood sugar. In this way, okay. If the kidney also affected, you can add urine dipstick for proteinuria. So be smart in the answer. Sometimes it doesn't need that much information. Just arranging your answer, it will show the examiner that you are oriented about the topic, even you don't know the medication. So the last thing we mentioned as a medication, mixilitine, for example, no one will ask about it, even if they will ask just to give you the full mark. But if you mention the things before, what we discussed, like the supportive, symptomatic, genetic, multidisciplinary team, counseling, education, complication, investigation, management of the complication, and the heart block itself, how to manage it, all these will give the impression to the examiner that you are aware about the topic itself, not about the pharmacological option only. Okay?
One thing I would like to add in the investigation would be pacemaker interrogation, and
Beautiful.
to comment that it's less likely to be faulty, but this can be done easily.
Beautiful. Beautiful.
Yeah. The programmer as well, one of the team, you could mention any pacemaker or any device, you have to mention the programmer, one of the teams who are important to follow the patient whenever he has this device, because this device, it's having life expectancy, the battery, so need to be followed up with this programmer whenever the patient is having this device in his body. The
So here,
instruction,
yeah,
yeah, sorry, the last thing.
I'm sorry.
Instruction before doing MRI, give him a card because those patients cannot go to the MRI machine.
Yes.
Okay?
So there is two types of devices here. That one that is MRI compatible, and also the pacemaker team would follow up the battery replacement. He would be having a box change, but whenever you are having pacemaker, don't forget to send blood cultures, please, because of the infective endocarditis.
Yeah.
Perfect.
As Dr. Omar mentioned, you have to specify there is compatible or incompatible devices to the MRI. Whenever you are talking to the patient, before he leave, he should have the card if it's incompatible. Because whenever this patient goes inside the machine, it will be distracted and it will not function again. Sorry. Okay. Any other question, Doctor? I had asked what is the fourth one? Possibility of cardiac device, pacemaker, CRT, ICD. I added Bermicath if you want to say, or
Yes.
something else.
I
Loop
also say
recorder?
a loop recorder too.
Loop recorder would be inside or outside?
Inside, but it will be recent scar,
Yeah, to be a
Emeka.
recent one, yeah.
I don't think that they will bring a patient with a recent scar, or
Mm.
if he does have a loop recorder, he will be too unstable to
Yeah,
attend the
it's
exam.
just a differential. A differential
Yeah.
that is
Okay,
likely to
perfect.
be.
So
Yeah, yeah.
put it in your mind, yes.
Mm,
Permicath, it's not related to the case, but
mm,
the same area of the skull and the same subclavian
yeah,
area.
yeah.
Okay. Any
Mm.
other questions?
No,
Any
so it's
comment?
just a refresher about the CRTP and CRTD. So they are basically just an added program to the box. So if someone does have a pacemaker and it already has three leads, one inside the right atrium and two inside the ventricles, this is bi-chamber pacemaker. So to change it from CRTP to CRTD is just a programming thing. It's not a rocket science. It's just a since we are mentioning the pacemakers. So what is the indications of pacemaker? This is could be one of the questions
Beautiful,
in a pacemaker
beautiful,
station.
beautiful,
Question
beautiful,
is
beautiful. Yeah,
So what is that, Emeka?
yeah. In this case, typically for pacemakers, indications for pacemaker
No, in general.
either could be due to body arrhythmia such as complete heart block.
Mm-hmm.
It could be due to second degree heart. It could also be due to what do you call it? Sinus tachyarrhythmias combined, which is sick sinus syndrome. It could also be due to if there's evidence of second degree heart block with with or that with what do you call it with I'll put it again. I'm forgetting this. Okay, let me leave that too. Also,
Mm-hmm.
another cause of pacemaker insertion could be if there's evidence of if there's what do you call it again?
So think about congenitals.
And,
Well, not congenital heart disease, I'm
yeah,
sorry, the inherited
for
diseases. What is
for
it? Three
for
things.
inherited for if it's ICD, that's quite different. That's quite different. That's not a pacemaker. If it's ICD, the indications are quite different. But pacemaker typically is body arrhythmias,
Yes,
basically, which can be grouped as either complete heart block or second degree heart block with severe second degree heart block, and also with sick sinus syndrome.
this
These
is
are the
good.
these are the three major indications for
And for the
for
ICD.
the ICD. It may be either as what as primary or secondary prophylaxis. If it is for and then that's for primary prophylaxis, you can give it for people what do you call it, inherited diseases such as hypertrophic obstructive cardiomyopathy. You could give
Mm-hmm.
them for Brugada syndrome. You could for as primary prophylaxis for ventricular tachycardia. Then also you could be as secondary prophylaxis for post MI. These are other
Okay,
indications for ICDs, such as following a post-myocardial infarction. So then
good.
also, these are, I think, basically, then for the CRT, indication for CRT, like I mentioned, could be when there's evidence of LBB with a
So
nerve vascular dysfunction, and
good.
a person must have a New York Association from 2 and 3, basically. Mm.
So yeah, so for the pacemaker, just a quick recap. So it is not limited to the bradyarrhythmias or tachyarrhythmias as you mentioned, but also in heart failure, where you have CRTP and CRTD. So they are both
No, that
pacemaker
when
BPM.
you say CRT, then you've added another thing. It's no longer pacemaker because
Yeah.
CRT is a two things. If it's just pacemaker, just normal
Good.
pacemaker, that's how you indicate. If it's
So the
CRT, there's
pacemakers,
indication
yeah,
for CRTP and indication for CRTD.
so for the pacemaker, what I'm trying to
Mm,
explain, so it's
yes,
just the pacemaker. If it's
yes.
a single chamber maker or double chamber pacemaker. So it would the usual patients would be on DDD. Okay.
Yes.
So
Yes.
DDD with pacing or DDD, I'm sorry, DDD normal or DDDR, that's fine. But what I'm talking about is that the general who is the patient will be worked up for pacemaker insertion. It will be also include the heart failures, particularly ECG, ejection fraction below 30,
You are talking about
35%.
the mode. What
Yeah,
you're talking is about the mode of pacemaker, not the
yeah,
indication. Now,
I
there's
know.
different mode. Eh? The mode of pacemaker is quite different from
Yeah, I
the
know.
pacemaker.
Okay,
Okay.
let's
Yeah.
collect the or gather the indication of pacemaker as a pacemaker away from the
Yes.
CRT. Okay,
CRT.
pacemaker for heart block. What type of heart block? The AV
Yeah.
block, the complete
Complete heart block.
or
From second
Mobitz
to
type
third.
2.
Yeah.
Yeah,
Yeah,
Mobitz type 2.
Yeah.
Or
Mobile type 2.
yeah, or symptomatic bradycardia, sinus
Mm.
symptomatic bradycardia,
Yeah.
or because of
6 sinus
medication
syndrome.
effect
Yeah.
and sick sinus syndrome
Yeah.
and medication indicated or beta blocker, for example, toxicity, patient on the lower side or symptomatic bradycardia.
Mm.
These for the pacemaker. The CRT for heart failure, as Dr. Omar mentioned, sometimes it can be associated or it can be put with the pacemaker,
Yeah.
but as a clear indication of pacemaker alone, what I mentioned, okay?
Yeah.
There is also indication for ICD,
Yeah.
which is a non-sustained VTAC, right?
Yeah.
And also for the HOCM patient, right?
ARVC
Yeah.
and Brigada.
Yeah.
Bulgarian. Like inherited
Any
body.
arrhythmogenic heart, yes. Any
Yeah.
arrhythmogenic heart, exactly.
Yeah.
Okay.
Then we also post MI as
Yeah,
So this is
post
the
symptomatic.
this
Yeah.
is the temporary. So this is the
Mm.
temporary causes. Sometimes they do classify it in temporary and permanent causes in the
Yeah.
pacemaker, not in the ICD.
Beautiful.
For the temporary, any patient post cardiothoracic surgery, he will be having temporary pacemaker. Patients with right MI, post MI, not right-sided, I'm sorry, the anterior MI that with bradyarrhythmia or tachyarrhythmia. And then the permanent, as Dr. Bassem mentioned.
Okay.
Yeah,
Thank you.
but I think it's beyond the basis. It's cardiac
Mm.
more than
Yeah.
to be basis exam.
Yeah, it's
Yeah,
just
but
to refresh the memory
okay.
about this.
Yeah, at least to know what are the devices can be connected to the patient, either ICD or pacemaker or CRT. And
Loop recorder and Vermicath. This is for
yes,
the scar.
yeah, the scar itself, yes. Okay.
Sorry, Dr.
Anyone
Basim, for ICD, ventricular tachycardia, ventricular fibrillation only, or other indication?
again? The what?
For ICD,
Yes. Yeah.
ventricular tachycardia, ventricular fibrillation.
Not only so, we have also the Brigada, and
Okay.
also we have HOCM. HOCM,
Yes,
you
yes, yes, yes,
must mention HOCM.
Yeah.
yes, yes.
Any
Those,
patient,
Yes, yes.
yeah, prone to have arrhythmias, in ICD will be indicated.
yeah, as a primary prophylaxis.
Exactly.
Yeah.
OSMI also one of the indication as mentioned
Mm.
already. Okay.
Okay.
Any other question, Dr. Salma or Dr. Nari?
Yeah,
Thank
no,
you very
I
much.
think it has been okay. Also, thank you, Dr. Omar, for your contributions. It has
Yes.
been a good one.
Always he
Yeah.
adds some
Mm.
important information. Thank you, Dr. Salma and
Yeah.
Dr. Henry. Thank you, Dr. Omar. Thank you, everyone, for the
Thank you,
attendance
Dr.
today.
Bassem.
See you tomorrow, inshallah, with clinical
Inshallah.
consultation day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Welcome.